JPS presentation, which we as a committee had requested to get their input. We'll take a 5-minute break while we get Lori to set up on her presentation. And Greg too? Yeah. Greg's going to do it? Okay. And then we'll go from there. So with that in mind, was there any further follow-up to this piece that we sent to you on questions and concerns that we still need to address? Okay, so hearing none, we'll just continue to move forward. Trent?
Yes, sir.
I think you're up to bat. I'm ready.
Yep. Well, thank you all. We appreciate the opportunity to give you a recap of the last several years of board work on this project. And on behalf of my colleague, Dr. Lowry, and all of you I think know Scott Fisher, D.T. Wynn has been at several of our meetings. We've had a good opportunity to stay in tune with Blue Ribbon work, and we've been giving systematically reports to our planning committee as well as our board of managers as to how the process has gone. So what we wanted to do today in response to the Blue Ribbon Committee's request that we give a board recap, to just give a little bit of where we've been at the board level, where we're going, and kind of where we believe this process is going to work. We have been very, encouraged and refreshed by the fact that even though the board hasn't been directly involved in any of the data that's been presented to you, there's been a very uncanny parallel with the work that the board has done. In fact, we've not seen one single instance of a finding that the consultants that have brought to you your recommendations have had with the work that we've been doing since 2009. So that's been encouraging to all of us that, these are becoming pretty obvious needs, and there's very little controversy or disagreement in terms of what those needs are. Just in terms of a brief recap, and I will not read these slides, I'm not good at that anyway. I'll point out a few things. As you look at this, JPS has changed dramatically since the last time we had a bond election. 1985 was light years ago when it comes to what's happened in terms of our population, in terms of our care. We see over 1 million encounters a year. Now at JPS, our level 1 trauma center is the only one between essentially Lubbock and Fort Worth. So those elements of our care have grown so dramatically. Our emergency department, for example, we see over 400 people a day. 5 years ago, we averaged about 175 people. When I first got on the board, we were wondering if we could handle 200 a day, and now we are over 400 a day. So we've hit a point, I believe, where being able to iteratively increase our care to meet the need has become almost impossible because of just facility challenges that we have. We have grown, we have staffed in order to accommodate growth to the walls when it comes to JPS's current facility. So we welcome very much the opportunity to make the next step in Tarrant County. Our contribution, and I won't spend much time on this because I think you already all know it, JPS is 6,500 employees. We have one of the most successful organ procurement centers in the country, 18 residency and fellowship programs. We have the largest family medicine residency program in the country. Other things that not on a slide that we do that matter very dramatically to the healthcare community is as the public hospital, we put up the dollars that allow the federal funds to be pulled down for the other healthcare facilities to be able to provide uncompensated care. That IGT process is critical for all of the hospitals in our area, and JPS, as the public hospital, is responsible for making sure those occur. Another thing that we like to brag about at JPS is because of our residency programs and our fellowships, we believe we increase the likelihood of primary care physicians staying in Fort Worth and staying in Tarrant County after they've been trained at JPS. We've got folks in the room today that trained at JPS. So we're very proud of the fact that this is our bullpen, and we're able to staff that ourselves and continue to bring more and more doctors into our county from JPS's presence. Our footprint, as you know, is a bit different than some healthcare systems. You look for Dallas County, for example, it's a very different footprint of how care is delivered. JPS is always focused on the community aspects of care through the clinics. And not all healthcare systems do that. It's a bit more expensive to be able to go out there and do that as opposed to one campus. But when you talk about access and the ability for people to access our care, the fact that we now have over 40 locations in Tarrant County means a great deal. It is not very, it is pretty frequently that we hear testimony from folks that are in our school-based clinics about the fact that were it not for those school-based clinics, they may not be able to get care at all. And we continue to grow in that regard. We always get more requests for school-based clinics than we're able to fund. The more we do it, the more people are exposed to it, the more popular it becomes, and I'm sure in this next budget cycle upcoming, we'll be asked again to provide more school-based clinics. It's been a very, very popular service for us. We have 17 primary and pediatric care facilities. And again, in contrast, not all public health care systems provide that level of service out in the community. We're very proud of the fact that Tarrant County has established that as a precedent for care. You've already seen the population numbers. We have seen dramatic population increase. Again, it has taken us to our maximum when it comes to our existing facilities. We are concerned about the demographics of our population curve, especially as it relates to the aging population and JPS's ability to meet that need. We do not have the facilities to meet that need, plain and simply. You know, we spent a lot of time over the last several weeks talking about the 26% and the portion of care that JPS provides. And I want to tell you that that 26% is really a product and not a factor, because that's what we're able to do, not necessarily what we would love to be able to do. We don't have any desire to go out there and try to expand into new markets or grow JPS for the sake of growth. We would like to be able to meet the demand of that population, and today we're limited to 26% of that population. So we get great care and great help from our neighborhood hospitals, from our friends in Tarrant County that also have to support a significant amount of uncompensated care. Were it not for that, I think we'd all be in a great deal of trouble. But the converse of that is, without JPS's provision of that care, what would the impact of that care be on all the other hospitals? And it would be dramatic and it would be significant. So our ability to continue to meet the need of that population really is what's predicated all of our discussions. It's not about trying to go out there and become something we're not, or mission creep, as I call it, to be able to go demand, go offer services that we had historically not provided. It's really about how do we break even? How do we continue to serve the population that we have today? That percentage, as it grows, how do we continue to provide it? And we have met the point where that has become very, very difficult to do. Just looking at our history, this is a little pattern of JPS's growth from 1913. Our last bond election down there on the bottom right was in 1985. We still have facilities being used today that were built in the second picture from the left on the top. We still have facilities that were built in 1939. And we're still utilizing those facilities today.
What was the amount of the bond in 1985? Do you remember?
Scott, do you know?
I believe it was about 40 million.
40 million?
45.
Thank you.
45 million.
Thank you. Okay. So what we're talking about today has been a long dry spell since the last bond election. And as you look, and we'll talk about this a little bit more in a minute, the fact that our failure to issue debt, if you will, is a testimony to some good things. The fact is we've been able to utilize resources without issuing new debt. And that's awesome. The fact is that our valuation in our community has continued to grow to help us meet that need without issuing debt. So there's no award for issuing debt, but the fact is, as we look at other hospital systems around the state, JPS has the lowest debt-to-asset ratio of any of them. And when we start talking about the level of facilities that we need, we've got to start seriously looking at that INS portion of our tax rate, because our M&O rate has been steady, and we've provided services through M&O. We have done, in my opinion, an excellent job of being able to, not have to issue debt. But there comes a point where you pass a point of no return. Some of you recall and were around back in about 2008, 2009, about the time I came on the board, it was not uncommon to pick up a newspaper and read a negative article about JPS. And the irony of that was it was in the face of massive amounts of surplus revenues. And that's a very difficult thing to be able to defend to people, is when you're sitting on millions of dollars of surplus revenues and care is not being provided, then that's a paradigm that's very difficult to defend. And so as the board transitioned, Mr. Early came in, the commissioners kind of gave us new marching orders. What happened was we really wanted to make certain that our dollars were being used for care. And so there was no longer any joy in having unnecessary reserves sitting out there that would theoretically be used in the future to build new buildings, because those dollars were not being used to provide care. And so there's been a shift at JPS, and we don't put a lot of stock in rat-holing money. We're trying to use that money for care. But the result of that, obviously, is that when it does come time to pay for facilities, we can't go and pull $500 or $600 million out of the reserves. So the debt piece of it becomes very important. When we talk about how this debt will be issued, I can give you a couple of commitments from our board, and these are very serious commitments. One is that we will not vote to authorize anything in bond money that goes to operations and maintenance needs. We don't intend to use debt to go out there and pay salaries. We want to use debt to build facilities. We want to use debt to create capital assets that depreciate, not use debt to subterfuge operations. And so that's going to be a significant commitment. And because we keep now, in my opinion, what are more healthy reserves that reflect dollars going back into our care, the need for the debt is demonstrated. And I think it makes a good point about where we're headed and where we've been. If you look at sort of, and I know that's way too small to read, but if you look at our history at the board level of what we have done relative to facility planning, we really started this back in 2009. We issued an RFP to begin facility planning. That RFP was awarded to Boca Powell, who over the next year built a strategic utilization facilities plan for us. That process went all the way through to conceptual recommendations. We have never, and I want to emphasize this, we have never said this is the magic number that we need to meet our need. The board has never put a priority 1, 2, 3, 4, 5, 6 on those needs. What we've asked for are what are the facilities that are necessary to provide the care that we are charged to provide. And in time, we will have to figure out what that costs. But there's never been a number from the board standpoint that we've said, well, we will only work up to this number, and then we'll stop. That's not been our trajectory. Our thought process has been, we are going to understand and determine what the needs are. We're going to measure those needs against our facilities. We're going to determine what levels of efficiency we can realize that help us avoid or reduce the debt portion of this. But this has never been about trying to figure out a number. It's always been about trying to figure out a level of service. It takes us all the way to 2016 when the Commissioners Court, after reviewing our facilities plan, began this process, and I think very wisely said, let's talk to the community. Let's talk to business leaders. We had over 140 meetings engagement meetings with our partners at JPS during the board's process. The Commissioners Court then took that to a new level by appointing this committee. So we believe that in all, by integrating the Blue Ribbon Committee and combining that with all of the stakeholder interviews that we have had and the meetings that we've had at JPS, there has been an adequate amount of vetting done to make sure that the need is publicized and that people understand where JPS is. So, 7 years is a long time to be working toward an event, and we hope we're able to see that come to fruition sooner than later. Our environment today at our system and campus level, again, our demand continues to outpace our ability to serve our patients. I had a meeting early this morning with the director of our emergency department, and I asked him, he said, Dr. Zenarosa, with 400 patients a day, what does it do to our ability to stay up with our metrics and continue to make progress on these metrics? He said, I don't mind telling you, it's harder and harder every day. because there comes a point where you just can't throw more physicians at it if there's no place to put them. And the rooms are full, and the rooms are backed up full. So we've hit that point where we've got to be able to say the environment today really is going to be best addressed through facilities utilization, understanding there's always efficiencies. There's always ways to work smarter, and we embrace that. But to be able to say that we can do this now without additional facilities, I think is, from the board's perspective, not a tenable position to be able to take. The primary preventive care piece, again, is one of those that is the most scary, just because we have so many more patients entering that age group where they don't have primary care physicians. We have always said that functionally, if we can't keep our people in panels to be able to see them within a reasonable amount of time in our clinic facilities, then it illustrates a serious problem in our system, and we are reaching that point. I want you to know that the amount of time and energy that we have put in to measuring quality since 2009 is remarkable. I will tell you that before Epic, before we had the electronic medical record system that we have today, there was a lot of unknowns about what JPS did and about how we did it. And about $60 million later, after Epic was implemented, we began to see holes in the process. We began to understand why some of the assumptions that we had were not backed up with metrics. Today they are. I don't think we as a board would be comfortable even going to the commissioner's court to say, support us with the bond campaign, if we couldn't say, here's the numbers, here's the data. And this is data that's backed up. This is data that can be supported from multiple different levels. It's data that reflects our physicians' input as well as our staff. This is not about anymore, sitting around budget and coming up with what we think would be a good metric. This is about now tying those metrics specifically to our reimbursements. We live in a world now that says if you can't make your quality metrics, you're not going to be paid. So we understand pay for performance. We live with pay for performance every single day. And our staff will tell you, and I'll tell you, I'm one of the guilty parties. Over the last 8 years of board meetings, there's very few meetings that take place where there is not some discussion relative to quality, empirical data that we can back up and illustrate JPS's need. So we feel more comfortable now than ever that when we say there is a demonstrated need, we can back that up with quality metrics and with data. And boy, have those quality metrics changed. You look at numbers of our satisfaction scores in 2009, and you ask, what that was to patient satisfaction, I can tell you, folks, we were below 5 percentile, some of the lowest in the country. Today, we're among the highest in the country. We were recently awarded from Modern Healthcare the award of one of the best places to work, one of the best hospital systems working in the country. That's not awards that go without a great deal of work. So the quality component of JPS, thanks to an amazing staff and an incredibly committed board and a committed commissioner's court, have demonstrated that this is the time. The need is now. And we're not in a position anymore of having to go make excuses because we don't have the data. We're not sure if that's the right number. Our scores don't reflect that this is a justified decision. We believe they do, and we're very passionate about moving forward with that. So what happens if we don't do anything? I think it's clear that the demographic and population growth is going to continue to overwhelm our ability to provide quality service. Our reimbursements will undoubtedly be jeopardized. We will be in circumstances where we're not able to pull down the dollars that we should because we haven't been able to maintain our quality metrics. Our inability to serve our population will negatively affect the other hospital systems. If our ED can't serve the people that are going to be showing up at our door, they are going to go to the other hospital systems. And they're not going to have a penny more to pay for that hospital care there than they had to pay when they showed up at our door. So there is an impact, and it's going to be a dramatic impact that we'll feel throughout the entire county, through all of the healthcare systems. We will experience higher costs. We are keeping some central plant elements in some of these older facilities. My granddad used to call it bubble gum and baling wire. And we're probably not that bad, but we're not far from that bad. It's when you appreciated an asset 5 and 6 times, and you're still counting on that asset to provide reliable services. We've had some unfortunate events at JPS. We've had generators that flooded and entire floors flooded because we didn't have the backup systems that we should have. So we believe that the facilities are at a point now that if we don't do something about it, there are going to be negative financial consequences. There's absolutely going to be negative care consequences for our patient population, and ultimately negative consequences for every single one of us that use commercial providers, every single one of us that, maybe JPS is not our home hospital. But if those facilities can't provide the care for us because of the additional burden they have had to take on because of JPS's inability, then unfortunately that tide will sink and all ships will lower. We feel that JPS is well positioned now for growth. And without getting into numbers, I want to just recap quickly for you where our money comes from. Property taxes pay for about 38% of our budget. Currently, the taxes equal about $227 on a $100,000 home. That's the real impact, right down to earth, about what it costs to operate JPS today. We have the lowest debt of any large public hospital in Texas and well below national averages. We have healthy reserves, but we don't have crazy reserves anymore, and that's by design. We will no doubt be able to contribute capital to bond campaign once that decision has been made. This will not be a circumstance where JPS hasn't thought at all about what to do. We have a future fund today with about $110 million, Scott, that's about right. Those dollars have been purposefully set aside to be able to reduce the principal on the bond campaign when it comes. And we feel that to show our responsible financial stewardship of tax dollars, we need to have a plan that shows our contribution of cash and assets to reduce that principal. So that's been deliberate, but it's not to the point that we would be able to, say, avoid a bond campaign, like what had happened in 2008 when they built the last expansion. We're not going to have that kind of cash. So we're at a point we believe this is a good time for JPS, and we are in a well-positioned financially. Thank God Tarrant County continues to be amazingly blessed with a very strong population, with an economy that most other counties in this country would kill for. And sometimes I think we take for granted just how blessed we are to be in Tarrant County. But it all points to the time, the conclusion that says if there were ever a time to make a decision about expansion of facilities and JPS's ability to care for its patients, now is that time. So this is in bold bullet points where the board has lit in terms of what our priorities are well before and long before the Commissioner's Court began the studies that you guys are seeing today. We have always said that we cannot deny or ignore the central plant, the campus needs. We are completely on board with the idea that health care is going to be in the future best provided at the community level because it will reflect the avoidance of having to have somebody at the campus. And our goal is not to create more opportunities to come to the campus, but we cannot let the campus deteriorate around us. There are campus elements that we have to facilitate. We have to do that with the same diligence that we pursue the community health care clinics and those things that take the population straight to the neighborhood instead of, or care straight to the neighborhood instead of, to the hospital. There's a world of people that cannot get to us. A world of people. It was incredibly gratifying this past week, and you've got the article in front of you, to cut the ribbon on the Northeast Medical Home. That will be the second medical home. And that concept is not just another clinic. That concept is to really fulfill what JPS's mission has always been, and that is, let's provide the care at the level where we can help the most and not be hit with the highest acuity patients who have not been able to see a doctor. We encounter patients at JPS that are 3, 4, 6 months, a year, 2 years past the point of being able to help. And we take that charge very, very seriously. We would like very much to be able to help those people at the community clinic level and be able to see a primary care physician. And when they call to get an appointment in a couple of days to see that primary care physician. And when they leave the hospital, there's a telephone call that says, we have an appointment already set for you at the clinic, and it's next Thursday at 2 p.m. Can you be there? we've implemented those steps, and we've got to be able to continue to do that. But that new patient tower is critical. If we're going to maintain surgery, if we're going to maintain our ability to provide something as simple as private rooms, we're not able to provide today at JPS. And from the HMA report, and you all read this, they said that that tower is no longer capable of providing acute care medicine in today's healthcare world. So we cannot deny the fact that there are dramatic campus improvements that need to be made. But we don't do that to the sacrifice of the concept that we still focus on the local delivery in the neighborhood to really make the best impact. Ambulatory facilities. This is one that you all, thankfully, have spent a great deal of time on. This is one that we at JPS, frankly, were a little nervous about because we understand how important an ambulatory care surgery center is. But because of the cost of ambulatory care, it's one of those that becomes very difficult to keep up there at the top of the list. We desperately appreciate the work that you all have done in illustrating what that ambulatory care model is. And I'll talk a bit more about that in a minute. And the psychiatric hospital. You've heard Wayne, you've heard presentations about why that piece literally, that floats every single boat in Tarrant County, folks, because that need is so dramatic. And we feel a little bit like the Lone Ranger when it comes to providing that care, that inpatient care. We spend a great deal of money having to contract out to go find people to help us provide that care. And unfortunately, they are not willing to do it for the same price we do it for. So, we're going to continue to try to meet the need. But when you talk about psychiatric care, there's probably no more demonstrated need anywhere in Tarrant County than that. So I've talked a little bit about the patient tower, the capacity issues, the quality and satisfaction issues. We're very proud of the fact that we have a very engaged physician staff now, a physician staff that feels much better about where JPS is today than it felt 10 years ago. And I think interviewing any of them would back that up. The operational efficiencies that we will realize simply from not hauling gurneys across the street, for example, which is some of the things that we do today, give us really, I think, a good trajectory on supporting the new patient tower. The psychiatric hospital, as I've mentioned, this is a life and death issue for us just from a safety standpoint. We have our psychiatric patients in some of the most untenable places you can imagine. How many of you have been on the tour, got to go on the tour? If you've seen that, then you understand. I don't have to tell you just how critical that need is. And boy, I can't tell you how proud I am of our psychiatric staff. I mean, Wayne and his folks have done an amazing job of providing care for those facilities. And Wayne, thumbs up, because he continues to do it. His staff continues to do it day in, day out. But there's a point where we have to say, Wayne, it's our turn. It's our turn to come to the table, because we're going to have to get you some facilities to be able to continue operating that care. On the ambulatory side, our capacity, our medical home, we rely on that as being one of those things that keep people out of the hospital. That concept is going to continue to grow. That facility in Euless is going to be like the facility in Arlington, and hopefully we'll be able to replicate that. When you talked about the ambulatory priorities that came from HMA, you saw 4 additional clinics. We don't want to build a clinic unless it has that patient population program that says we are going to focus on population health. We are going to try very hard to get people out of the emergency room and have a place locally where they can be served. Our ambulatory surgery center, and again, we appreciate the work you have done on that. We think that because of our surgery demand, this is a particularly important aspect for us, because we can take our turn time in a surgery suite from 25 to 30 minutes down to 10 to 15 minutes if we've got sufficient ambulatory surgical centers. So it's an expensive component, but one that would very certainly pay great dividends to us in terms of our patient care and our ability to continue to meet our own metrics. The stewardship of assets, there is no way for us to continue to be able to provide ambulatory care at the level we provide today without additional facilities. And I mean at the level we provide today. It's not just that how are we going to meet the growing demand, it's how are we going to meet the need today. So the ambulatory care piece, we are completely aligned with you and with the report that you've seen on how important that is for our future. I've mentioned, and I'll conclude with just a couple of more remarks, I've mentioned that we at JPS put a great deal of stock on metrics and about quality and about being able to justify and prove up what we've asked for based on real data that really is not arguable data. These facilities, if provided for Tarrant County, we believe will give us a comprehensive and integrated plan unlike any that's ever been in Tarrant County before. We believe that it can be done with minimal impact on the tax rate. There's work to be done on that, and at the end of the day, what we want to be able to do at the board level is work very closely with the Commissioners Court to make sure that we found that balance between providing the care, making certain that the resources that we're going to apply are used wisely, and that we have done it in a manner that reflects what the county needs as the paramount concern, not necessarily what the tax impact is going to be. But you can bet this is all going to be done in light of the resources that are available. None of us on the board are thrilled about the idea of bringing huge tax increases. We've all been on there too long. We know that environment. But the fact is, we don't want that to be the guiding principle. We want the guiding principle to be the care that we provide, how we've improved care in this community, how we've made Tarrant County a better place. But I believe you can trust your commissioners. They've demonstrated that trust in the past about using these resources carefully and applying these dollars in a way that we think will provide the best benefit for us. So as you look, I mentioned earlier that, you know, when you see the true numbers about where Tarrant County is in terms of its debt and our capacity, we are very fortunate not to have a great deal of debt, and we feel that positioning really best takes advantage of a very low interest rate market that we continue to enjoy. You know, we continue to put these things off, and eventually interest rates start to climb, and we pay much, much more dollars for the same thing. Remember, we started this back in 2009. The cost of construction alone since 2009 is seven-figure numbers. So we believe the time is right. We will continue to work very closely with the Commissioners Court on making sure that whatever ultimately is in the package reflects a concern for the recommendations of this committee, which we see as paramount, our financial capacity at JPS to continue providing care, the contribution of reserves in a responsible way that still keeps us above our reserve policy, and if there is an impact on the tax rate, that will be dealt with, and we will mitigate that accordingly. So, in summary, we've been working on this a long time at the board level. Really, 2009 was our kickoff point. Our goal has never been to expand facilities for the purpose of providing new markets or creating new commercial pay bases. Our goal has been to be able to provide the level of care to the patient population that we provide today and at least stay up with that and not get further behind. Our work has been geared toward reducing the need to come to the hospital. We continue to focus on that as our primary objective. We want to continue a culture of quality and compassion. We will continue to measure every single thing, every single day. We know that our reimbursements are directly tied to that. We feel that we would be literally acting in conflict with our core mission to do nothing at this point. Because if we can't provide the level of care that Tarrant County has come to expect for this population because of facilities, our core mission is in danger, and we will not be able to make it. We will work very closely with the Commissioners Court. We will take into consideration this committee's recommendations very strongly and look forward to being able to bring that to fruition. Finally, from the Board of Managers, on behalf of Dr. Lowry, Scott Fisher, who was on our board for many years, Chair, D.T. Wynn, who's been here many times, we appreciate the work that you put into this. JPS is the benefactor, and we're a blessed benefactor in that regard. Your efforts have been applaudable, and we appreciate it. I know it takes a great deal of time and energy to come down here and sit through these meetings. You know, we like to joke at the board level, we get paid in cookies. You've gotten paid in cookies just like we do. And we appreciate that time, we truly do. So with that, I'll conclude. Mr. Chairman, Madam Chairman, if there's any questions, I'll be happy to answer them. Thank goodness I have my staff surrounding me. They can help me out of a bind if I get into it, but I'll be happy to answer any questions.
Trent, thank you. It was a great report. Yes. while we've still got you here, I know that you've got another meeting you've got to run to, so while we've still got Trent here, does the committee have any questions for him? You like him to elaborate on any part of his presentation?
Could you do it again for me? I just
Yeah, Mr. Chairman, I do. Trent, I'm sorry, I'm not going to let you off that easy, okay? Would you walk us through a few things? First of all, I mean, I assume that we're going to make recommendations. Are they going to the Board of Managers for consideration, then to the County Commissioners Court? Is that,
The hope.
that would be the hope, okay?
That's right. We would like to take the Blue Ribbon Committee and vet that ourselves, so that when
Okay.
it does go to the commissioners, we've provided them all of our backup. Our staff has done everything we can to make sure that the data is reflected, and then we will be able to sit down with the Commissioners Court and be on the same page.
Okay, so in that case, would our recommendations need to include anything other than just facilities? Does it need to include timelines, financing, any of that?
I don't think so. I
Okay.
think if the Blue Ribbon Committee, through your scope, can focus on, has it been demonstrated to you that the facility needs that you have seen can be met with these steps, then I think the timing and the amount become really something we have to rely on the court to help us come up with. So I don't
Okay.
think we're asking for anything more than that.
From
at
that,
this point.
okay, so you don't want us to consider tax rates, financing, any of those issues in terms of what we're doing?
No, because at this point in time, I'm sorry, I should be holding this. At this point in time, that would be premature even from our standpoint. Again, we don't have a magic number in mind. All of us have talked about what this might be.
Right.
But until we can really sit down with our financial advisors and look at exactly how this would be phased and how that debt might be issued, we can't really articulate that in terms of a tax rate. And I apologize for the fact that it's difficult to be on a committee like this in your position and be asked to vote for something that I can't give you the exact cost or the exact time frame on. On that point, I'll just ask that you just trust us. Trust your Commissioners Court and trust the Board of Managers, because our interests are yours in this. And we've got to be able to do it in a way that's vetted, that's correct. Saying something now would put us in a position of having to defend it, and if it's wrong, we're all going to have egg in our face. So
Thank
we'd like
you.
to be able to put that off and get that vetted correctly.
Yeah, and I have another one. So, okay, that helps me, and I hope the committee understand what our scope is, what we're needing, or being asked to do. And so you've got $110 million sitting in reserve, and that's going to be up to you guys to decide about that, decide what else you put with it. That'll be the Board of Managers' decision, all that, right?
Recommendation to the Commissioners Court, that's right.
Okay, good. So are you speaking for the JPS Hospital in terms of the facility recommendations? I mean, we had asked specifically for, what does the hospital want? What does the hospital staff or operations staff want? Is that
I
what
am.
this is?
I
Okay.
am.
And so
This-
your recommendations matched up. Basically, what you just said was, we agree with our consultants' recommendations.
We do.
But you didn't talk about any of the options within those. Is there something needs to be said about those?
We have not, when you look at the big spreadsheet, for example, that says these elements could be added, and we'd recommend the consideration of these elements, I cannot speak on behalf of the board on those elements because they've not been presented to the board.
Okay.
The only ones that know about that are Dr. Lowry and I.
Okay.
And so until that can go through the board and can be vetted against the resources that are going to have to be applied to it, I don't want to speak for the board on things that they haven't seen. And there are components of this that the board has not been formally presented, so we will not try to speak for them on that point.
Okay, so we would need to include in our recommendations the options then?
Yes. If Blue Ribbon Committee believes that the options are viable, then we would love to be able to have Blue Ribbon Committee's full recommendation. And to the extent that that recommendation has to be parsed in some way,
Okay.
then at least we know what Blue Ribbon Committee's feelings were
Okay.
about that and the importance of it.
Okay, great, thank you.
Yes, sir.
I think we had a question, was it? I thought I saw a hand.
Yeah,
Was it you, Andy?
Trent, can you elaborate on the ambulatory surgical center? How is that different from the medical home? Is it expected to be a part of the medical home?
Now, the intent would be for an ambulatory service center to be on the campus, because we want to be
Okay.
able to take advantage of reducing the impact on OR, for example, where we're having to take up OR space with ambulatory cases today. That would remove that. And so the intent for the ambulatory surgery facility would be somewhere on the campus. and
Somewhere
it
on the
is-
campus.
It is designed within the facilities plan. And by the way, if you haven't had a chance to look at the JPS facilities plan that Boca Powell did for us. It is on our website. And we'd be happy for you to go out there and take a look at that. But no, this would be a central surgical ambulatory facility on the campus.
Okay, thank you.
Yes, sir.
Trent, I had one question for you, even though it won't have any impact on how I'm going to be voting. I'm just curious. Do you feel like, if indeed this all goes through, do you think we'll be at a AAA rating on the bonds, which would obviously be the lowest interest rate then? Do you feel pretty confident about that?
I do. We work very closely with David Medens and Hilltop and our financial advisors to make sure that we protect that. I would be very surprised. The only thing that we don't control about that rating would be at the time of issuance is if there is some gigantic uncertainty accompanying the macro healthcare delivery in this country.
Yeah.
We can't control that. But when it comes to what we can control, being able to reflect the stewardship that has resulted in that bond rating today, we intend to keep that.
Good. Thank you.
And just tell us how long we've had that AAA rating.
As far as I can remember, I don't know the genesis of it, Commissioner, but as far as I can remember.
Good.
Yeah, JPS, the county has done an amazing job of financial stewardship at JPS. I wish I could say that JPS has always been the care steward that we should.
Yeah.
But I do believe we are now. Yes, ma'am.
Mr. Petty, I very much enjoyed, well, enjoy is probably the wrong word, but I had a professor at Jarvis Christian College who said you have to be clear, clean, and precise in your work. What I am trying to make sure in my mind, what you want this Blue Ribbon Committee to do is kind of ratify, or, yeah, maybe ratify is the word, the usage where you as a board have already seen you need to go. So we looked at all these reports from consultants, and we've been and visited and all of that. And so you want us to help ratify the direction and the use based on our increase in population, our limited resources. And I guess my other part of the question is there a mixture? You talk quite eloquently about the balance between what you're spending and the usage that you're using the money for. Is there a formula where you break even, kind of?
The first part of the question first. I do not believe it's the board's intent to ask this committee to ratify the board's findings.
Okay.
I do believe it's the board's intent that you agree with or not agree with the consulting study that has been presented to you.
Okay.
The beautiful byproduct of that is the fact that they are almost perfectly aligned. And so the result is exactly the same, Madam Chairman.
So
But
we're extra eyes.
we are.
Eyes of.
And that's been the gratifying piece of this. As we went through our facilities planning, what we heard from these consultants was not only were we right, but if anything, we didn't go far enough. And that's understandable when our presentations were back in 2015. That 2 more years of the multiple effect of not having facilities shows up, and it's shown up in these numbers that you see before you today. It will continue to show up. So I do believe that we will appreciate ratification of the consulting studies that have been presented to you, and appreciate the fact that JPS has been headed down that same road.
Okay.
As to the second part of the question, I do not believe there is a formula per se that we can academically apply to this to say this is the right number. I absolutely believe there is a moral formula. I believe at the end of the day, Tarrant County looks in the mirror and they say, how important is this population of people to our county? And when we can do that and we're happy with the reflection that we see, I think we got the formula right. And that's a hard answer, and it's not an empirical answer, but I think it's a hard issue. I think we're at a point where we will be able to create the empirical formulas that warrant and justify the expenditures. Without a doubt, we will be able to do that. But we got to do the right thing. And if we do the right thing, I think we're all going to realize we had the formula correct.
And I think that's something I think this Blue Ribbon Committee wants to do, the right thing. Yeah. for our folks. Thank you.
Yes, ma'am.
Other questions for Trent?
I had one question for you,
Yes, sir,
Trent.
Dr. Simmons.
Getting back to the ASC idea, has there been any consideration to also maybe an ambulatory procedure center, which could further decompress cases that don't necessarily be done in ASC and provide it in a more efficient manner?
Not at the board level, but I know at the staff level that discussion has taken place. It continues to take place. And I think within that entire ambulatory services paradigm, we've got to be able to look at what those additional steps may be. And that's one reason I'm reticent to light on a number or a particular recommendation at this moment, is because once we finish with the Blue Ribbon Committee's recommendation, we want to take those things back and vet them and see maybe there is additional benefits to be derived from that type program.
Roy, you have a comment?
If I say no, will everyone be surprised? I think our hospital system has avoided accusations that we've tried to rush into anything. This has been a very studied and careful plan. Clearly, you look at it with a conscience and you say, gosh, why didn't y'all ask for a bond from 10 years ago? And maybe we should have. But we've done our best, I think, to study all aspects of this, including places like Maricopa County, who compare very positively to Tarrant County and how they've made a successful run out of their deal. The other sad reality of this, and excuse me, Trent, you've done a beautiful job. The sad reality is there are people who are going to vote against this just because it's about money out of their pocket. And the conscience part and the look in the mirror part is what I'm going to agree with. I think this board has gone about this in all the right ways. We're saying, may I, in the kindest way, and I think we're going to proceed one way or the other. It'd be real nice to have y'all's support. Is that okay?
Okay. Anybody else? Going once, going twice. Trent, thanks again.
Yes,
Okay, Greg, I think, who's doing the comparison
Yeah,
of
that's
the?
right. Just gonna-
Okay,
So
okay.
answering
Yeah.
one part of the question, right?
Yeah.
It might be, so if everyone takes a look at this package here that had the questions and concerns and goes about halfway in, you're gonna find, this chart that you're looking at up here. It might be difficult to see up here. So these were, just a few of the questions around, how do we compare to other like counties, like, systems? And one of them was around what percent of uncompensated care does JPS provide across the county? How does that compare to other counties? And the short answer is, looking at this, that it is very comparable in each one of those 4 counties, right? So we have Parkland, Harris, and San Antonio, University Health System. And they're all just a little above or a little below 50%, showing that those are, you all are incredibly important to the counties and to your communities to provide that uncompensated care. And as Trent was saying, important to those other health systems because you're taking on that care. Similarly, when we're looking at the percent of Medicaid, those are coming in around near the same. They're going up and above and below the 23%, which is where JPS is, but still around that range and relatively low on Medicare, and they're below 5% or around 5%, except for Harris, which is lower on both Medicaid and Medicare. So very comparable across those health systems.
Can you explain the Medicaid days? What does that mean? What does that metric
Yeah, so
mean?
when we have just the kind of volume, the number of discharges, how many are
How many-
discharged from that hospital, and then there's a number of days that each one of those discharges represent. So when there's a higher percentage of those Medicaid days as compared to the discharges, there's a longer length of stay.
Longer length, right?
The longer length of stay. That's making the Medicaid days come out different than the, so here.
So the smaller the number, the better? Is that?
Yeah, I mean, these are comparable. In other words, the on 22 versus 23.3, we see that the number of days that the Medicaid patients are at JPS are similar to other hospital systems across the county, because they're coming out the same, those two numbers.
Okay.
That's not the case in some of the other counties. Where
I'm trying to understand, comparing between JPS and Parkland, for example, it's almost double on the Medicaid days. What does that mean?
Right, so
What are-
longer length of stay as compared, at Parkland, longer lengths of stay for Medicaid patients as compared to the rest of the county, the rest of the hospitals in the county. Now,
Okay,
that's
so the
for
Medicaid
various
patient
reasons.
stays longer,
Yes.
almost twice as long at Parkland than they do at JPS.
So they are about 50% longer than their compatriots, than their other hospitals.
Okay,
And JPS is the same,
gotcha. Okay,
is how you might look at that.
okay, thank you.
So, about 50% more. So that's the difference. There could be a lot of reasons for that, so this is not an in-depth analysis of whether that's good or bad, but this is saying that these are.
Generically
around
speaking.
similar. Yeah, and that's a good thing, to have good lengths of stay. And it's also something that, if the uncompensated care was much higher, you would be hammering the number out, right? You want to have that be in a reasonable range, and yet you want it to be enough because that's the mission. So you're in the range of others. It seems to be a reasonable place. Let's see, we have one other, oh yeah, okay. So this was another question around, this is on your next page, around revenue breakdown. And if we look down on the percentage of revenue, so really on the bottom part is where you see how much of these different categories, this is the pie chart that was presented as well by Trent, that if we look across, these numbers of net patient service revenue and Medicaid supplemental funding added together are very similar across the system. University Health System does not report out the supplemental Medicaid funding separately, and so it is very likely tucked underneath that 65.9%, but not sure how that breaks out, because it's not, this is publicly available data. And on target as well as far as the property taxes, and we've seen that presented in various ways, but on target there as well. Any questions on these quite comparable?
On the net patient service revenue, are these numbers taken from what year?
So I believe these are 2016, yes.
2016.
Not up here, but yes, these are kind of publicly available numbers for 2016, yeah.
So would you attribute the difference between the net patient service revenue of JPS and Parkland to the fact that Parkland has a much larger, newer facility? It's basically double?
So the net patient revenues are about the same, though the budget's much larger. So
Right.
the percentage is much lower at Harris Health System. And we didn't look into, why that is. They have higher, if we look back, they have higher uncompensated care as well.
Right, they do.
Yeah, which would, be one of the reasons why potentially net patient service.
I'm trying to figure out the correlation between the two. You see what I'm saying?
Yep, so,
Okay.
More uncompensated care, less net patient revenue, more of their activity supported by supplemental funding.
Okay, thank you.
Can you go back to that prior slide? So that, I'm still kind of stuck like Commissioner Wynn on some of these numbers, but when you said the 45% is the percentage of the uncompensated care, that first column?
Oh.
At that
Yep.
JP?
Uh-huh.
Now say that goes down to 35%, does the rest of that just drop off the map, or does it go into the?
That would be to other hospitals.
Do they automatically pick it up? That's what I'm trying to.
Yeah, because it's 100% of the uncompensated
Okay,
care
but-
across the county, so we will
Well, I understand that principle, but
Yeah.
I'm really talking about the human beings. If someone,
be paid.
if JPS can't fill up to the 45 in the future,
Yep.
does some of them fall off the grid, or do you think they all find their way into
I think
private
we
hospital?
find a way.
Right, so the
They
community
find a
health
way.
need assessment community health need assessment and the current data would suggest that it's a combination, that there really are, unmet needs out there now, and to have any pullback would create more unmet needs. People,
But they'll find their way to a private hospital though.
some will, absolutely.
Yeah.
So it's kind of a combination.
Okay, thank you.
I think, don't you think though, the vast majority in an acute situation, they
Exactly.
know to get to a hospital and call 911, and so if JPS is closed, they're gonna end up down here at one of the other
Exactly.
hospitals.
Emergency room,
Yeah.
way up.
Yeah.
So when you talk about, maybe ambulatory primary care, some shift there, but on the acute, absolutely, all connect place.
But landing in somebody's emergency room is not the same thing as getting comprehensive care. When patients without resources land in a non-public hospital emergency room, then the responsibility of that hospital is stabilization.
Well, it's stabilized and it's
treatment,
also to
too.
treat if they have the capability to treat. So for instance, if a patient ended up in a hospital that did not have an OB program, so mom's in labor, they don't have anybody that can deliver that baby. So they're gonna stabilize and get that lady to the nearest women's program if they can do it safely. However, if they do have it, then they have to treat, and they have to treat it at exactly the same level as anybody else that comes in that ER. That's the old EMTALA law from the, 86, I think, is when that was first put into effect. And I can tell you that there are exceptions, but we're talking less than 1%. That's one of those laws that hospitals do not like to cross. There are very hard ramifications for a hospital that does not treat a patient that they are capable of treating, whether it's cardiac care, orthopedic care, whatever. Now, to get to your point, a lot of the trauma that JPS takes care of, these hospitals could not take care of. They just don't have the capability. So there's kind of a mix there.
I would submit to you that delivering a baby is different from providing continual care for a chronic disease, and that's not likely to happen.
Now, chronic disease, that's a whole different group of patients, for sure. So I
But
agree
it
with
is
you.
a group of
I agree
patients.
with you on that.
Yeah.
Yeah.
Diabetic that shows
Yeah.
up to the ER and sure is stabilized, sent out.
Kinda
and they
clean
get
'em
a
up.
hyperglycemia,
Yep, and then
event.
on out, yeah.
Absolutely.
Yeah. So point well taken, Commissioner.
Okay, so one other thing that was asked about is this kind of percent of need on the primary care side. And really this is resources available. So this is looking at what kind of primary care capacity is there in each one of these counties. And that primary care capacity applied towards that population in the county, how much of the under 250% FPL could that capacity serve? There are a lot of assumptions across these, other health centers, things that we did not look at or control for. So we should just keep that in mind, that there may be a much different payer mix of University Hospital, for instance, that just is not in here. Is that capacity being used for that population or not? So that part's not in here. It's just saying, here's a capacity that these systems have, and if it were applied towards that population, what would that look like in each one of those? And we do see that, there's a disparity we see there, that there's a lower amount at the JPS, the capacity currently available for the population. Again, there may be a lot more of that put towards the 250% FPL, so that part of the comparison has not been done. We're missing the one other, but if you could see it, and I'll put you ahead one more slide here in your papers, and it's this one here. And what that's showing is really the one next biggest FQHC. So there are other sources of primary care, particularly for the under 250% FPL, that's available. And this is saying, okay, that one next largest FQHC, how much capacity are they bringing to bear for that same population? And so this just tells you a little bit more about what percent of the population is covered in that particular county. And it does, as you see, and there's assumptions here as well. This is built entirely off of revenues and not looking into their actual delivery of care. It's assuming that a certain number of visits can be done or are being done based on revenue. So these are very high-level looks at this, but certainly there is a lot more primary care capacity at the 250% FPL in these other counties. Arguing, I think, putting more weight toward what you've already, kind of put weight on, which is building up more ambulatory capacity.
So I want to reflect on the number that you asked to go back to, please, for just a second. And that is if you take these numbers, the old statement that figures never lie, but liars sure can figure. That's from Poly High School. 1967, but who cares? Anyway, JPS is shown as 45% of the county uncompensated care, and the other hospitals are 54.6. Well, you think, well, gosh, JPS isn't much doing their share. Please refer back to that there are 39 hospitals reported. Divide that 54% by 39 hospitals, and that means each hospital is providing about 1.25% of uncompensated care, and JPS is providing 45%. That makes that fraction look real different. And I can't say that the 39 hospitals are equal in what they do, but it really states to the fact that they're not. Stuart Flynn told me one time that in Arizona they talked about how, well, we're all providing our uncompensated care. If you look at that number, they look like heroes. And yet the fact is, the real hero here is Trends Group. So.
Huge percentage for one
Yes.
hospital. Yes. Other questions or comments on the rest of the answers that were in the packet?
I'm still struggling with the revenue breakdown. Can you help me clarify this? The revenue from Parkland compared to Harris is more than 300 million. How could that be? Harris is a lot larger. And then if you look at the other table, which basically shows Parkland percentage of county uncompensated care cost is about 60%, compared to Harris is about 52%. So the difference there is only 8%. So the revenue projection, it just doesn't add up to me. It doesn't.
Yeah, so here what you're saying is you're seeing a large percentage for Parkland in the uncompensated care. Large percentage. And then when we're going here, we're
Would you look-
seeing a large net patient revenue service line. And those are the two pieces that you're saying.
Right, and Harris County is a larger county.
Right. Right. They don't have as big of a total revenue as Parkland per the publicly available data.
Okay. Which seems odd to me, but I'm just,
Well, I wonder about the Harris health system too, in that you have the medical center down there in Houston, and you have, I think, 2 or 3 level 1 trauma centers all through that area. I mean, they're within blocks of each other. And I don't know if that breaks it up in some way. I mean, I'm just saying, what you look at DFW, you got Parkland over there, you got JPS here. You go down to Houston, and everything is centralized towards that medical center. And I don't know if that changes the dynamics of it or not. I really have no idea. I mean, has anybody worked, have you worked down in the Houston area, Scott, or anything? I would think in some ways it has to change the dynamics of what goes on down there, but I don't know.
Yeah, and certainly in Harris and Houston, there's a lower percentage of Medicaid and Medicare to support their activities, which then, results in this kind of higher tax support of 48%.
Right.
So those pieces anyway hold together. But I hear what you're saying on this particular piece of the Medicaid revenues perhaps being larger than one would expect, given the numbers here for Parkland. I don't have an answer for why.
I know, I'm just want to make things a little bit more confusing.
Mission accomplished.
Yeah, got it. You got that done.
So this means JPS is doing okay.
Doing very well. Yeah, within the community, it's a very important provider of uncompensated care. And really doing it in a way that's still drawing in significant Medicaid and Medicare to support that mission. So, I think in terms of balance and how that compares to the others, that is on target.
Well, and just so everybody can understand, there's been conversations amongst some of us on the board and administration how to better service this ambulatory care portion. And the medical care homes are great and terrific, and it's sort of complex to get one going. Trent, and y'all took quite a while to get that one developed. And so, in places like Alameda County in California, they can forgive me for taking license with them, but they're trying new things. Where's the best place to locate clinics? Schools are great because they're in every area of the community. Guess what else is being tried and we're looking at right now? Fire department guys will be calling each other tonight, but guess where the fire stations are? Right in the neighborhoods. If you can winnow off from a fire station with a primary care clinic without developing a complete medical home, you provided another service care center. So we are using our imaginations here, some of us, to see where we can go next. I don't want to read about this in the paper tomorrow that I said we'll be using fire stations. My house will be burned down tonight. But you have to get creative with this. And the medical home, as ideal as it sounds, is not going to solve all the problems. And if you just got to go to a local fire station to get your blood pressure checked, or to check your diabetes and your sugar levels if you're not so good at it, how handy is that? So we are still looking in our system at other options.
And that gives more personnel, medical personnel out there, because usually the EMS people know how to do this stuff.
Right.
Or with a minimal amount of training,
Well,
they can.
the facility becomes used by two parts of our community, Fire Protective Services and our hospital. Okay. And you're going to staff it with a nurse and physician level or equal, PA or nurse practitioners. So it's just one other thought, and I just share that because I want y'all to know we're not just wondering, well, how many medical homes can we build? We're looking at other distinctive options, cost effective.
Just parenthetically, the CEO that built the Alameda County system trained at JPS.
Huh.
Really?
Yeah. Okay, so no more questions for Greg on
Greg, you skate. Good job.
That's a tough one, because I know those charts, everybody's counting the data a little bit differently, and it is just so hard to make a apples to apples
Yeah.
comparison, but thanks
You
for,
really have to delve in
Yeah.
more
After this.
detailed.
yeah. Let's take a 5-minute break as Lori gets all ready to go, and we'll be right back.
Yes, I'll be back.
No.